as an intensivist in the Addenbrooke's Hospital, but he's also a Wellcome Trust Clinical Research Career Development Fellow. He has obviously got a particular interest in neutrophil dysfunction and critical illness, and he's going to talk to us about C5a Mediated Neutrophil Dysfunction, how exaggerated inflammation leads to immune failure and nosocomial infection. Thank you so much.
Thank you, and sorry for such a mouthful of a title. Good morning, and thank you very much for the huge honour that it is to be here to present my work in this session. What I'd like to do today is take you really on the journey I've been on over the last 10 years during my research, seeking to explain what I see as a paradox at the heart of the syndrome of critical illness. And I hope to illustrate the clinical insights that can arise from fairly fundamental biology, but I assure you there are no Western blots in this presentation, so don't worry. In terms of declarations, one of the studies that is presented in this was done in collaboration with a company, BD Bioscience. I didn't get any personal profit from this, but they did fund the study, and we have an ongoing collaboration with them. So, critical illness is an inflammatory syndrome, and I don't think that's a controversial statement. We see it in our patients in ICU macroscopically. You know, they're pyrexia, they're tachycardic, they're hypermetabolic. We see it at a cellular level with proliferation of immune cells and release of immune cells, particularly neutrophils, into the circulation, as well as activation of pro-inflammatory cytokines, complement system, and coagulation. And of course, we know there is immune-mediated organ damage, perhaps most obviously seen in ARDS, where the inflammatory infiltrate impairs oxygen and gas exchange. And of course, you'll all be well aware there are preclinical models rather, which demonstrate the benefits of immunosuppressive therapies or immunomodulatory therapies in animal models of critical illness. But, and this is what I call the sort of paradox of critical illness, is that although sepsis and its sterile equivalent SIRS are characterized by hyperinflammation, our patients are extremely susceptible to secondary infections. Their rate of secondary infections approaches that we see in frank neutropenia. And the bugs that cause infections in our patients are rubbish. Acinetobacter, Pseudomonas. We don't see infections in healthcare professionals exposed to the same environment from these bugs. And yet we know healthcare professionals can pick up infections from their patients. We've seen that with Ebola, with SARS, with H1N1. So these bacteria and fungi tend not to cause infections in immunocompetent hosts. And we also know that infection is the commonest mode of death in our patients. Multi-organ failure precipitated by or exacerbated by a secondary infection, even if you come in with a sterile insult in the first place. And, of course, we lack a specific disease-modifying therapy, particularly in sepsis. And that's not for lack of looking. The history of our specialty is littered with failure, sadly. And these drugs just don't work. Anti-IL-1, anti-TNF, high-dose steroids, activated protein C. None of these drugs have been successfully translated into clinical practice, or at least not for very long. And why is this? Well, I would argue that it's because we're approaching critical illness, and I am lumping it all together here, a bit like the six blind men approaching the elephant, each of us looking at different bits of it, but failing to put the whole thing together. Now, I'm not the first person to say this. So Roger Bone, who was instrumental in developing the SIRS hypothesis, or the SIRS syndrome back in the 80s, realized as the failure of anti-inflammatory therapies was becoming obvious that something else must be going on. And he suggested that what we saw was what he said a sort of compensatory anti-inflammatory response syndrome, or CARS. And in this diagram here from Richard Hotchkiss's paper a couple of years ago, they suggested that patients with hyperinflammation with the SIRS syndrome were dying in the sort of early deaths, and then later on they were developing this CARS syndrome, getting nosocomial infections, viral reactivations, and ultimately late death. The problem with this conception is that CARS is a theoretical concept. There's no demonstration, no one's ever demonstrated the CARS phase as a distinct phase in either human or animal work. And it fails to tally with what we see in our patients. Yes, our patients definitely get nosocomial infections. Yes, they get viral reactivation. But those things start to resolve as the systemic inflammation settles down, as they start to recover. And that's when they stop getting these secondary infections. So this is kind of where I was when I started on this, on my sort of research journey in Edinburgh 10 years ago. where I'd moved after having trained in Glasgow. And there I met two people, one of whom will be very familiar with you. It's, Tim Walsh is obviously a keynote speaker here at this conference. And the second chap is a guy called John Simpson, who's a respiratory physician who's now in Newcastle. And Tim and John had set up a project looking at ventilator-associated pneumonia that formed the basis of my PhD. And when I started, John said to me, Andy, we found that the neutrophils in patients with ventilator-associated pneumonia don't work very well, and I'd like you to find out why. So I said, well, that's very interesting, John, and went back and got out my first-year immunology notes and reminded myself what a neutrophil was, and then started to have a look and try and work out why the cells weren't working. And one of our first findings was that ventilator-associated pneumonia was associated with a profound alveolar inflammation, so very high levels of pro-inflammatory cytokines in the alveolar space in patients with VAP. And that led on to a whole different story that I'm not going to talk about today. But what was striking was that the neutrophils from the alveolar airspace in these patients were even more dysfunctional than the neutrophils from the peripheral blood in these patients, despite this very pro-inflammatory environment. And so it was whilst I was thinking about this and reading Peter Ward and Marco Thuber-Lang's work on complement activation in sepsis, animal-evolved sepsis, I started thinking about C5a. So just to briefly remind you about the complement cascade, what we have here is several bacterial and antibody-mediated activations of a plasmolytic cascade, each component activating the next component. And what's important here, what I want to draw your attention to, is what happens when C3 is split and C5 is split. And they form C3b, which goes on to activate C5, but also releases an anaphylotoxin, C3a. And C5 similarly releases an anaphylotoxin, C5a. Now that name, anaphylotoxin, describes what they do. So if you administer C3a or C5a to an animal, you induce a pro-inflammatory response, vasodilatation, recruitment of neutrophils, and a SIRS-like syndrome. And to sort of cut a long story short, we went on to show for the first time in human critical illness that C5a exposure correlated directly with neutrophil phagocytic function. So we showed here that the patients had significantly impaired phagocytosis relative to a group of age and sex-matched volunteers. Now, the problem with C5a is it has a very short plasma half-life, and I think probably the main reason why this finding hadn't been noted before was precisely this. If you measure just C5a levels, it doesn't reflect necessarily what the cells have seen, so we needed a proxy measure. And one of those was CD88. So the main receptor for C5a is CD88, and when C5a binds to it, it is internalized and downregulated. So the lower your CD88 on the surface of the neutrophil, the more C5a it has seen. And you can see here that low CD88, more C5a, worse phagocytosis. As another proxy measure, we looked at C3a, which you'll remember from the previous diagram is upstream. And with C3a, the more C3a there is, the more C5a has been generated, and the worse the phagocytosis is. Now, this was correlation, but we went on to have a look at what happened if you exposed healthy volunteer cells to C5a in vitro. And we used an assay based on the ingestion of zymosan particles. These are large yeast cell wall particles. And we showed that if you expose them to C5a, you could induce a similar defect to what we saw in the patients. Now, I'm not going to show you another dry graph. I thought I'd show you a little video, hopefully if it'll work. Yes, here we are. So this is a control-treated neutrophil eating a zymosan particle. Okay, I think it's quite beautiful. And this is a cell treated with C5a. So it's not paralyzed. It can still move around. It puts out its little pseudopodia there, but it can't facilitate effective phagocytosis. So something's going on here. It's a bit unusual. And when we published this, it was a sort of reasonably controversial finding and met with some skepticism, although I hasten to add it has been externally validated subsequently, both internally within my own group and externally by others. But people said, well, what's the mechanism? And that was this paper here. And the summary of this paper, and in fact the summary of my 3.5 years of PhD is this slide here. Now, this is the only pathway diagram in this talk. But as it took me 3.5 years to generate, I hope you'll bear with me for a couple of minutes as I just go through it. I'm still rather chuffed with it. Essentially what I showed was that C5a binds to its predominant receptor CD88, activates an intracellular signaling molecule called PI3K delta, which inhibits RhoA, inhibits actin polymerization, which prevents phagocytosis. Importantly, if you treat the cells with GM-CSF after they've been exposed to C5a, so this is in vitro, but after they've been exposed to C5a, you treat them with GM-CSF, you can restore Rho-A activation, actin polymerization, and phagocytosis. And the same thing happens if you took patient cells and treated them, again, ex vivo. Now, it was at this point that I moved to Cambridge, returning to my town of birth, and I came to join the nascent critical care biology group being set up by Charlotte Summers. And I took the opportunity to work with Edwin Chilvers, who's a neutrophil biologist and respiratory physician, and Klaus Okenhag, who's an expert on PI3 kinase biology. And shortly after I'd arrived in Cambridge, I met a guy who I hope you guys in Australia are going to get to know pretty well over the next few years. Alex has been my first PhD student. He's just finishing up. He's a native of Perth, Australia, and is shortly going to be returning to your country to start as an intensive care registrar in the Royal Melbourne Hospital. And I tell you, our loss is very much your gain. And when he started, pretty early on, as he was struggling a little bit with my Zymazan-based assay, he said with a sort of typical Aussie directness, and I'm not going to imitate his accent, but he said, the trouble is, Andy, yeast just isn't very relevant. And I said, well, that's probably true. It's a shame, because I've built my career on this assay, but there you go. Anyway, Alex, being a practical kind of lad, went on to develop an assay which is much more physiologically relevant. And this was an assay, essentially a model of bacteremia, where he takes whole blood and he exposes it to bacterial particles, E. coli, Staph aureus. And you can watch the cells ingest using a flow cytometer. And rather reassuringly, he's demonstrated that C5a not only inhibits the ingestion of large yeast cell wall particles in purified neutrophils stuck down in a tissue culture dish, but also the ingestion of something that's far more pathologically relevant. So this is E. coli and Staph aureus. Now, Alex wasn't content with just developing a single assay, and he's gone on to develop a system for getting phosphoproteins out of neutrophils. And that's quite a tricky task, given the propensity of neutrophils to release lytic enzymes and auto-digest themselves when disturbed. But he's overcome those difficulties and has produced the deepest phosphoproteome from a neutrophil yet described, 2,500 phosphoproteins, which may not sound all that impressive, but believe me, it really is. And when the cells are exposed to Staph aureus, a whole load of pathways light up. About 800 proteins are differentially phosphorylated, and they light up pathways across a really wide range. Oh, whoops, sorry, I've gone ahead of myself there. A really wide range of pathways. Now, the next couple of slides contain unpublished data, so please don't photograph or tweet them. But this was the volcano plot that we got. So this is the 800 proteins that are changed in response to C5a, in response to Staph aureus. And this is the log fold change along the bottom here, so it's sort of essentially how much change there's been, and this is how significant it is. How on earth do you start with a data set like that? 800 proteins, where do you go? Well, thankfully, in some ways luckily, under the C5a treated conditions, only 19 proteins are different. That looks a lot more tractable. And I'm just going to focus, these proteins map broadly onto two pathways, and I'm just going to focus on two of these. One, Z516 up here, which is a PI3 kinase responsive element, thank goodness. And the second one down here, which is VATPase, which is responsible for acidifying the phagolysosome. And the results on the next slide are literally hot off the analyzer. So they just came last week, just before I came here. So this is the cutting edge of my research. And again, I hope you'll forgive me while I geek out slightly on stage, because we've developed a probe for looking at simultaneous assessment of phagocytosis here along the x-axis and acidification of our phagolysosome on the y-axis. And what we can see here is that over time, the cells start to eat and start to acidify. Importantly, however, you can see in the C5a condition, they eat less, we already knew that, but also they acidify less. And this population down here is very interesting, at least to me as a geeky neutrophil biologist, because this is a group of cells that have eaten but have failed to acidify, a population which largely disappears in the control group. So C5a is not only inducing a failure in phagocytosis itself, but also in the maturation of the phagosome. And maturation of the phagosome is critical to bacterial killing. But so what? Patients don't really care whether their neutrophils phagocytose or not, or acidify their phagolysosome, even if the target is pathophysiologically relevant. And of all of this that we've seen so far, just been an epiphenomenon of infection. Patients get it as they become sick. And of course, their neutrophils are sick too. And of course, can we do anything about it? So to answer the first of these questions, is this simply an epiphenomenon? We went on to conduct a single-centre study. It was based in Edinburgh. And we recruited patients as they came into ICU, so before they got their secondary infection. And we used flow cytometry to measure CD88 as our measure of neutrophil dysfunction, monocyte HLA-DR as the sort of established measure of immune dysfunction in monocytes, and the proportion of immunosuppressive regulatory T cells. And we showed that this was a high-risk population, so we managed to recruit a group of patients who got a lot of infections, obviously bad for them, but good for the purposes of our research. And we showed that each of these measures was associated with a subsequent development of infection. So low CD88, C5a Mediated Neutrophil Dysfunction, low monocyte HLA-DR, and an elevated proportion of these regulatory immunosuppressive T cells were all associated with development of secondary infection. And interestingly, they combined as well. So that if you had only, well, none of them or one of these, your risk of infection was relatively low. But if you had 2 or 3 of these dysfunctions, your risk of infection was really quite high. Now, this is a single-centre derivation study. So the next step was to go on and perform a multicenter validation study, which we published earlier this year in intensive care medicine. And here we recruited patients from 4 ICUs across the UK and undertook flow cytometry in 3 different flow cytometry hubs. And they're geographically distinct, so we had to make sure that we had cross-site standardization, which, again, for those of you who know about flow cytometry will realize the challenge involved in that. So, modestly bigger study than the last one. It was smaller than we'd intended to, but as ever, we ran out of time and money. But again, we had a strikingly similar rate of infections, and again, pneumonia was the commonest. And once again, rather gratifyingly, all 3 of our measures were significant predictors of subsequent infection, albeit less well-performing than they had been in the original study, but then that's very common for validation of markers. And interestingly, we had the same combined effect. So if you had 0 or only 1 of these dysfunctions, your risk of infection was relatively low, but 2 or 3, and your risk of infection was really quite high. And now just to show you a little bit of unpublished data here, we also measured a few other markers while we were there because we had the opportunity to, and that wasn't part of the validation study, but as a sort of exploratory part. And if you add in a further 3 markers, so this is PD1, programmed death 1, which you may have come across in the literature, CD312, and the expression of HLA-DR, this time on dendritic cells. If you add in these 3 additional measures, the predictive ability or discriminant ability becomes even better, and we can start to substratify our patients further. But how would we use these tests clinically? So working with a guy who, again, will be familiar with many of you, a chap called Manu Shankar-Hari, who stood on this podium only a year ago, and is an extremely good guy who helped me a great deal on this project. So Manu and I worked out a model for how we might use them, and we said, well, let's take the best performing measure that we had, which in the validation cohort was monocyte HLA-DR. And if that's high, then we'll say, well, you're low risk. If it's low, then we're going to go on and measure CD88 and Tregs. And if they're normal or within normal range, then again, you're low risk. But if one or other of them is abnormal, then you're high risk. And at day 0 in our study, which is about 36 hours into the patient's ICU stay on average, being in the high-risk group as classified by these markers was not a predictor of subsequent infection, not a prediction of prolonged length of stay or days of organ-free support. But by day 2 to 4, which is about 3 to 5 days into ICU, at this point, they do become predictive. So your risk of infection goes up, and these patients stay in ICU for longer and have more organ support days. Now, it's not that these markers aren't present at day 0, and indeed Manu and Tim and I have only last week published a paper showing that different measures of immunosuppression, but measures of immunosuppression predict outcomes to some degree in very early infection in the emergency department. And these markers are definitely present when these patients are admitted to ICU. Why do they only become predictive at day 2 to 4? Well, I think it's partly to do with the persistence of the dysfunction and the sort of degree to which the patients have been exposed to that risk. And that's why we start to see predictive ability at this stage. Well, that's all well and good, but what are we actually going to do about this? So, we know that our patients have neutrophil dysfunction. We know why they have neutrophil dysfunction, but can we do anything about it? And if you remember back to my mechanism slide, I'd shown that GM-CSF was able to, in vitro at least, restore neutrophil function, both in healthy volunteer cells treated with C5a and patient cells. So the next step was to try that in actual patients. And this was a study that was led by John Simpson, so my former PhD supervisor in Newcastle. And we recruited critically ill patients with impaired phagocytosis. So we stratified our patients, and we used our old Zymersan assay, because Alex's new assay hadn't been developed at the time when we were working on this study. So we recruited patients with impaired phagocytosis, and we randomized them to subcut GM-CSF or placebo for 4 days. And the primary outcome measure was a biological outcome measure, which was change in phagocytosis at day 2, with secondary outcomes being further measures of phagocytosis. So essentially, restoration of normal phagocytosis as we had defined it, and the area under curve, so sort of cumulative phagocytic capacity. So we recruited 38 patients, 17 GM-CSF and 21 placebo, due to the study design. That's where the imbalance comes from. 13 patients and 13 GM-CSF patients and 20 placebo patients received at least 2 doses, which is what we'd intended them to do, and I'll discuss a little bit why we lost those couple of patients. On the intention to treat analysis, there was a very non-significant difference in phagocytosis, which was slightly disappointing, although arguably intention to treat analysis is the wrong way to look at a biological endpoint, because the question is, does GM-CSF restore phagocytosis? Not, is GM-CSF an effective therapy? That's a different question that we couldn't answer in this study. So if we looked at the proportion with restored phagocytosis by day 7, so it's phago above 50%, more than half the cells eating. In GM-CSF, that's all of the patients by day 7. In placebo, less than half of them. So that is significant. And if we just took the patients who got at least 2 doses of GM-CSF, again, the difference in phago is relatively modest, but it is significant, at least in the unadjusted analysis. And if we look at area under curve for phagocytosis, again, we can see the patients who got GM-CSF have a bigger sort of phagocytic capacity over the duration of the study. So where did those disappearing patients go? Well, we had 3 safety withdrawals in GM-CSF, 1 before the patient got any drug at all, so I don't think we can blame the drug for that, and 2 after a single dose. So 1 was for thrombocytopenia, 1 for transaminitis, and there was 1 safety withdrawal in the placebo. We lost 2 patients to follow-up because we had to bleed the patients in order to measure their phagocytosis, and they were then transferred out of the unit. There were no drug-related SAEs and no SUSARs, and no signal to harm in terms of organ failures. And I think one of the difficulties we had with recruiting into this study, leaving aside the logistic difficulties of trying to do phagocytosis assays, was that clinicians were concerned that GM-CSF might exacerbate organ failure. There was no signal to that. Mortality, study's not powered for mortality, but again, no signal, and in fact, in patients who got 2 or more doses, definitely no signal to harm. And ICU-acquired infections, again, the study wasn't powered for ICU-acquired infections, but those that did occur in the GM-CSF group, the vast majority occurred within 24 hours of starting drugs. That's unlikely to be modifiable by the drug. So this study's been useful, it's been interesting, and it's given us a lot of sort of food for thought about how we might design the next study. So to conclude, our patients are systemically inflamed, but also immunoperitic, a kind of worst of all possible worlds. And this apparent paradoxical situation may be, at least in part, explained by the ability of pro-inflammatory molecules in general, and C5a in particular, to drive neutrophil dysfunction. So my sort of updated version of the schematic that I showed you from Hotchkiss's paper from a couple of years ago, earlier on in the talk, goes like this. In uncomplicated infection, you get a bit of inflammation, and you also get a bit of anti-inflammational dysfunction, but it resolves pretty quickly. Patients get better, they go home. In more severe infection or persistent inflammation, the sort of ones that we see in our ICU, you get more severe pro-inflammation, but also more severe dysfunction. And if you're unlucky, that dysfunction then predisposes you to a secondary infection. You're double hit, you get more inflammation, more of this immunosuppressive phenotype, viral reactivation, further infections, and ultimately late death. So this immune dysfunction can be readily phenotyped using cell surface markers, and possibly our new rapid test of rapid functional test may also be proven to have clinical utility as well in subsequent studies. Neutrophil dysfunction combines additively with other dysfunctions. So we can't just look at one cell type, we need to look across cell types in order to phenotype our patients. and get them into the right studies. This is going to allow us to identify patients who might benefit from immunomodulatory therapies, but we need to work out which immunomodulatory therapies, what dose to give, and at what time. And I hope that further exploration of underlying mechanisms will hold the prospect of novel, new non-antibiotic treatments for infections in intensive care. And I would ask, please do look after Alex when he comes back to Australia, because I hope he will provide the substrate for many years of ANZIC's trials to come. So thank you very much. And just need to acknowledge, obviously, the many people who've been collaborators, mentors, and supporters over the years. I couldn't have done this work without them. And, of course, the people who've paid for it all. So thank you very much.
Thank you very much, Andrew, for that very thought-provoking presentation. Are there any questions from the floor? Okay, well, no? Lauren? Okay.
Hi, me again. I was trying to give someone else a chance first, but so Jack Awashina and others have published on persistent critical illness, and we all know that there is a large literature out there on chronic critical illness. Do you think that neutrophil dysfunction and these mechanisms that you're exploring might be more prevalent in that population?
So I'm absolutely sure that in the chronic critical illness population, so the ones who stay in ICU for a long time, who have ongoing features of inflammation, will almost certainly have neutrophil dysfunction. Absolutely. I'm pretty convinced that the neutrophil dysfunction develops very early on. And I think if we pick up our patients early on, it's just, the question is, does it resolve or not? And I think it's the resolution that gets them out of ICU. It's why they don't get their secondary infections. Whereas if it persists, then they get into this chronic phase. Now, obviously, it's not entirely the neutrophil, and I like to think it's mostly the neutrophil. But, I have to accept other factors might be important. But I'm pretty sure that it is. Now, we haven't done those studies well enough to be absolutely certain. So, our studies either have recruited very few of these these long-stay patients, or haven't run out long enough to be absolutely certain. Mm-hmm. But what we do know, and from work that Dave Griffiths was doing in Edinburgh just as I was leaving, was that the patients, as they recover, once they get out of ICU, even though they're still pretty sick and have persistent ongoing inflammation, their neutrophil function, at least in our assays, had returned to normal. So I think return to normal in immune function is an important measure of your ability to get out of ICU, and I suspect it's causally related, but I can't prove that yet.
Thank you. Jeff, I think you've got a question.
Seems to be the same two people asking questions. I have a question. We've found that about 40% of our patients in ICU meet the biochemical definition of scurvy, and which is really quite disturbing. Yeah. And there are very high levels of vitamin C within neutrophils, and vitamin C is very important for neutrophil function. Do you suspect or think that low levels of vitamin C might be in some way impacting on some of your findings here?
I mean, it's a very good question. The simple answer is I don't know, and it's something we should definitely look at. And, there's obviously been some interest in vitamin C therapy in recent years, not necessarily being hugely well conducted, but with suggestions that it might make a big difference. Maybe that's a mechanism. We should certainly look at it. The one thing I would say about vitamin levels, we have to be very careful about measuring them. When I was an undergraduate in Glasgow, a few years before that, they'd be measuring vitamin levels in their patients in ICU, found them, they were all vitamin deficient, and it wasn't just because they were Glaswegians. But when they looked at intracellular vitamin levels, they were really quite different from serum levels. And what was happening was they were pooling their vitamins sort of essentially within the red cells, they measured them. So yes, I think nutrition for our patients plays an important role, and there may well be a specific role for specific nutrients if we can identify them. But we need to be careful how we measure them, I suppose, is what I would say.
Yeah, thanks very much.
Yeah, go for it, Andrew.
Obviously, with HUS, eculizumab, or whatever it's called, have you looked at using that? Obviously, the expense would probably put you off a bit, but...
intensive care is extremely expensive. I think we can afford to splash out on a few expensive therapies. So yes, eculizumab, which for those of you not familiar with it, is an anti-C5 antibody, which is used in nocturnal paroxysmal hemoglobinuria. Is that right? PNH. And it blocks C5. And there have been some animal models work with sepsis that suggest that it might improve outcomes, which, we have to be a little bit careful about animal models. They've not necessarily been entirely predictive in the past. The concern, I think, is that patients who are treated with eculizumab do have an increased risk of Neisseria meningitidis infection, or Neisseria infections. So I would sound a note of caution there. Complement itself is obviously really important for bacterial destruction. If we block C5a directly in our blood assay using an anti-C5a antibody, so it's a preclinical antibody that's been developed by a drug company, it really impairs phagocytosis and bacterial killing. So I'm still cautious about anything that might look a bit immunosuppressive, is what I would say. But we shouldn't discount it, and with the proper workup and safety work, we could certainly look at it as as a possible therapeutic.
Great, thank you very much. I feared we were heading into the old magic bullet conversation all over again, but we haven't. Thank you very much for that, and thanks to all the presenters. That was an absolutely spectacular hour and a half, I think. Really enjoyed it, and thanks again.